Thank you. Good morning. Good morning, everyone. You guys want to move up? I'll open the table for questions. We're here to learn about EEG. If you have any questions about EEG,
I have a question.
yes, ma'am.
So I was talking with one of the seizure dog people groups out there.
Yes.
And she was saying that if your EEG shows a certain type of spike,
Yes.
how do you know if your EEG, how do you know if that spike is on there? Like if I'm looking at it, how do I know that that spike is there?
Okay. Well, this is where this thing comes handy, right? So your brain activity is very dynamic. It changes. As I'm speaking, it changes constantly. So one EEG that I take now may not be so helpful to the one I'm going to take an hour or two later, right? Because the two of them could be completely different. One other factor you need to consider is if you're taking an EEG while you're awake versus an EEG when you're asleep, totally different things. Because you're more likely to have abnormality on your EEG when you're asleep. That's why the weight of an EEG is a lot more when you capture a sleep segment on the EEG. What do I mean by that? If I tell you that your EEG is normal during awake and sleep, to me it weighs more than a normal EEG only in awake. Okay? So there are, when I talk about dynamic, it does not imply to state by state. It also implies by age, because 1 week of EEG in, let's say, a 1 week old baby is totally different than a normal baby 2 weeks later. So it's very dynamic, right? So her question was, how do I know if I'm having spikes? You're not going to know unless you know how to look at EEG. But to make it simple, your brain waves really like this, right? And sometimes it drops down in amplitude, sometimes it goes up, sometimes it slows down when you're getting sleepy or drowsy, right? And then there are certain waveforms that we know, that guy is in stage 1 sleep, that guy is in stage 2 sleep, that guy is in slow wave sleep, that guy is in REM. There are signatures. And then there are time lines on your EEG. So we could count, say, okay, he's awake, his eyes are closed, so he's generating 1, 2, 3, 4, 5, 6, 7 cycles per second of wave. So for a 7-year-old, that's normal. For you and I, that's slow. We need to be generating 8+ waveforms every second when we are fully awake. Now, however, if it's close to noon, you're hungry and you're sleepy, your waveforms might slow down, right? So going back to her question, a spike, there are two abnormalities primarily seen in patients with tendency to have seizures. One is a sharp, the other one is called a spike. These are defined by the duration. So a spike is 20 to 70 milliseconds. A sharp is 80 to 200 milliseconds. Remember, I told you there is time gradation on the EEG. So if this is 1 second, there are 5 lighter lines inside. Like that, right? So, for example, if I do this, if I blink, that's 200 milliseconds. A normal blink. If I'm awake and I blink, that's 200 milliseconds. So I'm going to look like this. Like that. Quick. Okay? A spike, a sharp, is actually even shorter than that. So if this is 200 milliseconds here, a sharp is going to look like this. And a spike is going to look like this. So there is no scientific thing to say, I mean, that's a spike, that's a sharp. It's just because they look like spikes at the time.
On my daughter's,
Yes.
I've seen hers. The
Have,
whole thing is those.
huh? Say that.
All of those.
All of them are spikes.
I mean, there were a few, but
Majority are spikes.
yes.
Yeah. I mean, so having sharps and spikes does not mean you're having seizures. Sharps and spikes are indications that that person has a tendency to have seizure. The other side of that you need to know is if you look at 2% of people, right, never had seizures, you're going to see that, no, if you have 100 people in the room and never had any seizures, 2 of those will have abnormal EEG. It doesn't mean they are having seizures. So the presence of sharps and spikes alone does not tell you anything about that person. You need to listen to their story. So, if someone is having seizures, the spikes are going to come one after another. So it's going to look like this. And then when the seizure is going to stop, the spikes come down in amplitude and then it slows down. So you see a person having generalized seizure, they start jerking like this. And then if it's going to finish, they go back. So they go like this. The spikes get faster and higher. And then when they're going to finish, they slow down. So they reverse. So you know, watching a person having generalized tonic-clonic seizure, you could watch and say, that person is going to be done in a few more seconds. Because the jerking slows down and they become less in amplitude. Amplitude meaning the amount of jerking that you're going to see. So much so at the end, you may see them jerk once in a while and then eventually stop. So the presence of spikes that are frequent does not also mean that they're having seizures. Because remember I said that there is a pattern. There are people with what we call ESES, electrographic status epilepticus of sleep. When they go to sleep, each page of their EEG is spikes, 80%. So it depends on what you see on your daughter's EEG. And then when we read the EEG, we say the density of the spike is 80% of the page, but they're not having seizures. Or they would say, well, I mean, these discharges are developing and organized. It looks like a seizure. So we would say that at the end of the reading. Subclinical seizure basically say that you're having seizures on EEG and no manifestation clinically, right? It looks like this.
So a bunch of spikes could be subclinical seizures depending on the frequency?
You have to have a pattern, yes. So there is a pattern that you see in an ictal discharge on EEG that tells you that's a seizure. It normally develops into a pattern. It starts slow, it progresses, and then it dies down. So seizures usually don't begin like that. You see an end. I mean, you see a start, you see a progression, and you see the end. Yes, yes. The only thing where that is different is in patients with absence. Does anyone know what absence epilepsy or absence seizure is? Absence is, because the name implies, it used to be called petit mal. So it's called absence because you're like absent or not there for a few seconds, right? Typical 10, 20 seconds, right? So I'll be talking to you and then I keep on going. There is no post-ictal state. So if this is 1 second, I'm exploding the EEG, right? What you see is this. So that's a spike and a wave, a spike and a wave, a spike and a wave. 3 times per second. So that's the signature of absence. 3 hertz, spike and wave, discharge. So you have 3 spike and wave. So if you actually see one and watch one having a seizure, they blink. Their blink is 3 per second. It's time locked to the spike and wave. And if it's actually more involved, you actually see the head do that. Yeah, yeah.
Her eyebrows.
Yeah, you see that, they move. But not everyone does that. So this pattern, they don't have the progression like this ones. They start and stop. They start and stop. So what typically happens during an EEG, we ask the patients to hyperventilate, right? You could actually time how sensitive they are to hyperventilation. Some people, they don't get to 1 minute. 20 seconds, that's all it takes. And then they start like nothing happened. So 10, 20 seconds. But the problem with these kids, they have hundreds, or could have hundreds. So if you could imagine 10 seconds each, 100 a day, that's a lot of seconds. You're absent. So they go home and they tell their parents, I didn't get any homework. Because they were handing out homework when he was having one of those. So absence is an exception to the progression. Myoclonic seizures is an exception, because what you see in the myoclonic, yeah, they just do that, right? So if this is 1 second, you see this, and then they actually quiet down, and the jerk comes right there. You see the spikes, big spikes on EEG, and then 100, 200 milliseconds later, the jerk comes. Big ones. Some big,
So the spike comes first and then the jerk.
the spike, yes. Because the reason why that's a good question. If I do this, I just move, it's not a seizure, it's going to create this thing on EEG. But the movement is at the same time as the EEG showing the same abnormality. So the spike needs to come before the jerk. And there's usually 100 millisecond lag.
So once we see the jerk, she's already been in the seizure.
See, if it's a seizure, what you see on EEG is a spike, polyspike, high amplitude.
Because she has lots of those myoclonic jerks.
Yeah.
Sometimes.
That's what usually happens. So you have a spike, polyspike, and then the jerk comes.
So when we're seeing the jerk, the previous part, she's already kind of been in a little...
Like
the
this.
seizure's already been going on.
Right. Yeah. And then there are seizures that look like this. Like, no, are you guys familiar with the infantile spasms? You know, the babies that they do that? They do this, you see the spikes, and then the EEG becomes suppressed or flattens out. We call it electrodecremental response. Everything just kind of shuts down for a few seconds. Yeah. So there are different signatures to EEG. Absence has 3 per second. Juvenile myoclonic epilepsy has 4 cycles per second. Lennox-Gastaut, 2 hertz spike and wave all over. No normal background. Some even don't have a normal sleep pattern. The infantile spasms, we call them hypsarrhythmia because it's really very abnormal. So we watch out for those. But what I want you to know is EEG is not a good test. I mean, it's not. Even in people with epilepsy, if you run an EEG, 50% of the time, it could be normal. It doesn't mean that the events they are having are not seizures. So the most important thing in epilepsy and seizure diagnosis is talking to your patients. Tell me what an event looks like from start to finish. What do you see first? Yes. We could tell. Yeah, you could tell that's why also when we have EEG, we have the video. Because it could be very hard, right? If I do this and she's getting an EEG, I do this, I could make her EEG look like she's having a seizure, right? So I do this.
That's what I always wondered. I'm like,
yeah, you could. Yeah. That's why we have to have the video. Okay. And most parents, like for babies, right? They're sucking on a pacifier or drinking a bottle. You could see suck artifact on EEG. Or they pick them up after feeding and they do this. And then you see this thing on EEG. Looks like a seizure. So you have to watch.
So is it like if they're not moving?
Yes. It's hard when you're moving because your EEG could look like this when you're moving. We could do filters and try to minimize the movement, but it's not going to be good. And so sometimes I read the EEG that it looks normal, but the quality is so poor because of the movement. So if you're thinking of seizure, you need to bring this kid back and maybe sedate the kid so they don't move as much, so you get a good quality EEG. Spikes, probably. Yep. Yeah. The number of spikes go up when we go to sleep. There are some people with the abnormality only seen when you're sleeping and normal during awake. There are actually people who are only having seizures in their sleep, not awake.
Spikes go for everyone or only for people with epilepsy?
Spikes what? Say that again. Go. Those are the epileptics. Yeah.
So he can have spikes and
not have seizures. Yeah. Oh yeah. Not everyone with spikes have had seizures. Yeah. So here is a good example. I always tell this to my residents. So if we are all brothers and sisters here, right? I have absence, the 3 per second spike and wave, right? And there are 100 of my brothers and sisters in the room. I could run EEG on all 100 that's related to me. 60 of them, 60, will have the same EEG abnormality as mine. But only 6 of those 60 will actually have seizures. Okay? So that's the other big limitation of EEG. So 3 hertz spike and wave. I told you already this is the hallmark, the signature of absence, right? This is the most common genetically inherited EEG abnormality. So if I know the sibling has absence, I run an EEG on someone, the mother said, well, my daughter is staring as well. Can I bring her over and say, okay, fine. We run an EEG and you see the same thing. It doesn't mean they're having seizures, right? Because of what I told you. 60% will have the same abnormality, but only 6% will have the actual seizure. So I have to see a seizure on that kid before I put them on medication, which is easy. You put them on an EEG machine, you hyperventilate them. If they're having absence, they're going to have absence if they're not on medication.
So on a normal schedule you have EEG, what are they looking for and how can it help them to treat their
Your kid.
your kid.
Okay.
So like for instance, I got scheduled for over the weekend EEG. Did not have one seizure. As soon as they got to their car, he had a seizure. So now it's like he wasted a whole weekend. Well, I won't say wasted, but he was there for a whole weekend. Didn't catch a seizure, but he got one as soon as he got to his car in the parking lot. So now what I want to get to is like if the doctors see the EEG, a seizure on the EEG, how can it help them to help you treat your kid?
That's a good question. I'm going, before I, yeah.
Also, what should I be looking at? Because my daughter hasn't had the EEG performed in 2.5 years. And if the doctor tells me, like, we need to schedule you one, why? What should I do?
Okay. So I'm going to start with your last question. So it's normal practice if we diagnose you with epilepsy, right? You put you on medication. 70% of kids will outgrow their seizures. So 2 years later is when we decide whether we could take you off the medication. So your last question, doing well, no seizures for 2.5 years. I said, let's go get an EEG. And then after the EEG, and then I could talk to you about the result and whether your daughter or your son could come off of medication.
Well, my daughter still has seizures within the last 2 years.
Yeah, if you're having seizures, having another EEG does not really help you unless you're questioning, do I have the diagnosis right? Do I have this kid on the right medication? So part of your question can be answered by EEG helps you in trying to decide what kind of seizure that patient is having, because I told you there are EEG signatures, right? And it will tell you whether that kid is more likely having partial or generalized seizures. The main deciding factor we use when we choose medication is based on seizure type. There are partial medications and there are medications that work only for generalized. And so EEG sometimes could help you with that. With partial, so you have left or right, you're going to see spikes on just one side of the brain or one location in the brain. Generalized, the abnormality you see are on both sides. That's why it's called generalized. And therefore, the seizures should be generalized, then you put them on a medication that helps generalized seizures. You see partial, you see and you hear partial seizures by history, you put them on partial medication. Patients with partial medications, however, whether they're controlled or not, they could generalize. So they could start, let's say, on the left temporal and eventually spread to involve both sides. You still treat them with partial medication because if you control partial, they don't have the secondarily generalized. Now, your first question, that's not an unusual story, unfortunately. We bring them to the EMU, we call it diagnostic because they're having spells. We call them spells because we're not sure whether they're having seizures or not. So I say, okay, before I put you on medication, I want to bring you to the hospital. I'm going to put you on a continuous EEG, and hopefully during that 2-3 days or a week that you're going to have one. Because if you're going to have one of your typical spell on EEG, I should be able to tell you if it's a seizure or not. Right? So that's the goal. Before I commit you on a medication, remember I said 2 years. That's a long-term commitment to medicine. If I'm not sure, I'm not going to put you on medicine. I mean, medicine has side effects. Unfortunately, you're in a different situation. You're not at home. The stress is gone. They just bring you your breakfast, lunch, and dinner. You don't even have to clean up. They make your bed, right? You don't have homework. You know, you're so relaxed and you don't have seizures. And then the minute we take them off the machine and they're in the parking lot, that's when they start. So what? They get called again. Hey, your patient you just discharged is in the emergency room now because he had a seizure in the parking lot. That's not unusual. Again, I'm going back to Epilepsy 101, is listening to your patients. You tell me what's going on, what happens when you have one. Some people say, I feel weird, I get this just a weird sensation in my stomach, and then I taste something in my mouth, or I smell something that no one else smells, or I hear something, and then what happens? And then my head starts rotating to the right, my eyes go to the right, you know. So you have to listen. Okay, they can talk to you. We always tell the parents. Nowadays, actually, it's amazing. If you, who was that yesterday morning? Before you could even introduce yourself, a new patient, right? You come to the room. What do? They pull their phone and say, "This is what he does." That's the best help you could get. Pull your phone and take a video of the event. Whatever your seizure or anything that makes you worry that your child could be having seizures, pull the event, pull the video. Yeah. Well, then you need to tell the doctor what do you think? Is that a seizure or not?
So like the EEG will catch it exactly on the side of the brain it's happening?
Yes. If you have been running the EEG and it's recording well, and you have a seizure during the EEG, I should be able to tell you if it's partial or generalized, or I could tell you. And if it's partial, I could tell you potentially where it's coming from. There are things we listen to make us classify seizures, whether it's partial or generalized, whether it's complex partial or simple partial. Those are the old names. That's okay.
So whenever we were in for our son's 96-hour EEG, we had no idea he was having an absence on top of those grand malls. So that's something that the EEG enlightened us to, but we didn't know how to recognize those at the time. So is there a way that you can use the data from the EEG that maybe you aren't able to see? Like, we've gotten better about recognizing some of the absence, but I think there's still a lot that we miss at home. So is there a way to use that data as a reflection, like to come back and say, oh, this is what that looks like?
Yes. The problem with absence is exactly what you said. It's so hard to tell whether a child is having absence or not, right? And so, one, you're not going to see the first absence of any patient, because by the time they get to you, they've been having absence. And so the diagnosis is so late for people having absence. Even on treatment, it's so hard to just gauge whether they're doing well or not. So one of the things we look for is people who are having hundreds of absence, they usually don't do well in school. I mean, it's understandable, right? So you put them on medication, and guess what? One of the first things that the parents tell you, oh, he's doing much better in school, because they're not having the absence spells. It's so hard to quantify absence. It's going to be too hard, yeah. And so one of the things we do when we say, okay, our parents are still complaining that the child is having staring episodes, we say, okay, let's put them on EEG. One day or 2 days. And if your EEG is clean during that 2 day, or especially if the parents pressed the button and said, okay, I just saw him stare, and then said, no, it was not a seizure, then I'll be able to tell you, okay, you see what he's doing on video? That's not a seizure. You see what he's doing on video? That's a seizure, because his EEG looks like this. No, I mean, you could always open the book. I mean, it's never closed, right? I told you already, it's a very active participation between you and your doctor. So don't say, okay, fine. I've seen the video. You have to. So what do you think of the video? Is that a seizure or not?
My son started a new medication and he's not having generalized seizures anymore, so he's
I mean, I would even back up before answering what type of seizure. It could not be it may not be a seizure.
I mean, he can't talk. He's definitely having a seizure, but he's walking around and trying to get places. I talked to his doctor. He asked me, we haven't had it. He said that the new medication is controlling the seizure in this one area and avoiding it in one area.
Well, I mean, there are partial seizures coming that could come from any part of the brain, right? So, most common partial seizures are temporal. The temporal lobe seizures are quiet when they start. So you'll be talking to the person and they stop. And then they start moving. So complex partial seizure of temporal lobe is quiet for the first part, and then they start moving. Complex partial seizures from the frontal lobe. So I'm not saying that your son is having frontal lobe, but that to me, if that's a partial seizure, would be extratemporal in origin. Because frontal lobe seizures especially, they move right from the start. So they are, and they may not be organized movement.
It's like zombie.
Yes, yeah,
Could they generalize?
yes. Any partial seizure could generalize.
Because he's having them at night.
Yeah.
And there's no monitor that's picking that up. The only thing is like we hear like the gas, like yeah. But I'm so terrified that he's just gonna have those at 2 in the morning and not generalized, and nothing's gonna happen until we wake up at 8.
Unfortunately, that's the truth, right? And I told you already, seizures are more likely to happen in sleep. People who have, 10% of people will have a single seizure in their lifetime. 10%, right? And if you're going to have a seizure, it's going to happen in your sleep. Because our brain's tendency to have seizure is highest when we're sleeping. Your ability to maintain is less. A good example is in REM. Everything is turned off in REM. Your body temperature regulation is turned off in REM. So you wake up in the middle of the summer and you wake up very cold because your thermostat is off if you're waking up in REM. All your muscles are paralyzed in REM except your eye muscles, your heart, and the muscles that make you breathe. You remember picking up your baby's arm and you say, she's awake, because you see the eyes moving underneath their eyelid, they're in REM, because rapid eye movement, pick up the arm and they just drop, because they're paralyzed. Yeah.
I got a generalized for about 13 years and then stopped, but we're suspecting absence. So we've had lots of 3-day EEGs, and they said, no, it's not possible. We didn't see a slowing of a wave. Is there did I hear that right?
Yeah, there
Would be a slowing?
there is a 3 per second spike in wave in absence.
So even though she's not having them during her sleep or not having them during the day?
Yes, especially if you're not on medication.
Okay, so she's on still on medication.
Medication could clean your absence EEG abnormality, so you may not see it.
But she still could be.
Well, if I record her on a 3-day EEG and you tell me she's staring, I should be able to see the 3 per second on EEG.
Okay.
If I don't see it, then the staring episodes that you see are not seizures.
Okay.
So that's the utility of the EEG.
And like all the other EEGs we have, either overnight or in the hospital, those events don't happen when we're hooked up. I think it only happened once, and we've had probably 10.
So your daughter has both absence and generalized seizures?
We have generalized early on, who's been on some pretty heavy medications, but every time we try to have the EEGs, it doesn't happen at that time. Only one time of all the EEGs. But I wanted to know if I heard that right.
Yeah.
She would definitely be able to see us.
Yeah, if you're having seizures on EEG, I should be able to tell you
Okay.
if it's absence.
Even if
Yeah.
okay.
Interictal, that's a different story. Right? In between seizures, I could clean up your EEG if you're having absence, if you're on medication. But if you're still seeing staring episodes, that are absence, if I record it on the EEG, I should see it. So going back to your comment earlier, right? I told you that 70% of kids will outgrow their seizures. Knowing the syndrome, like epilepsy type, for example, if you have absence, 85% of them will outgrow it. So knowing the type helps you in talking to parents and say, okay, well, I have good news and bad news. Bad news is your child has epilepsy. Good news is he's got absence, and there's an 85% chance that he's going to outgrow it, right? There are two types of absence, the childhood onset and the juvenile. The childhood onset, they primarily have absence. The juvenile, they have absence plus generalized tonic-clonic, which is probably what your child has. And there are medications that control only this, and if they're having this, you need to put them on another medication, or choose a better medication that will control both, so you end up giving just one. So this is what I mean by knowing the type of seizures your child is having, because it dictates the type of medication we can use. And nowadays with gene testing, type of medication you shouldn't use because it could make it worse.
We tried to do the genetic testing and it got insurance won't approve it.
Tell me about that. I live in Central Valley. We have Kern County down at the south. We cannot get anything done when they get out of their county to do anything. Yeah, it's so hard.
Just trying to get insurance out of it. We're from Oklahoma, so neurology. One thing we did is we go out of state for all of our care, so we called our insurance. We were able to get a caseworker from city care back here. We kind of had to go through a couple of loops, but we just kept pushing, kind of pushing it.
Yeah, where do you live?
We live in Bakersfield.
Hello, Kern County.
Yes, and Marissa goes to that when she sees Dr. Fu. But it's almost what, she just got the VNS in June.
Mm-hmm.
And we have an approval letter for that. And then in September, they denied it. Like, are you kidding me right now? You already approved it.
Look at the letter, and we've seen one or two of those. Bring us the letter.
I took it, the social worker, I can't.
Yeah, Caitlin, I was going to
Yes.
ask you to get to talk
She
to her.
has it.
Yeah.
And I mean, we're fighting it, but
Yeah.
it's like everything. It just,
So your daughter has CCS?
she has subcortical band heterotopia.
No, but is
She
she
has, no,
with
she has, we have Anthem Blue Cross.
Anthem Blue Cross?
I don't even,
For our son, we got the VNS in 2009, so I opened up my Excel spreadsheet, and I said how much is it costing, and this is gonna reduce the cost, so I did the math for them in order to get approval.
well, she
Like,
already,
listen, if you approve it,
There's that she had an approved already.
No, but the genetic testing, you can
Oh.
say, listen, if we brought the right diagnosis.
Oh, I see. I gotcha.
Save you this amount of money.
How you justify? Yeah.
And all that. They're all about the money.
We have a couple of those that we got approved. We did the procedure, and then the parents called us and said, "Hey, guess what? I got the bill." Yeah.
yeah, it's a hefty bill.
Oh, I know. Yes, ma'am.
About the 85% that outgrow it.
For a specific seizure type, right?
Okay, so after
In general, 70% will outgrow it.
generalized onset seizures, diagnosed at age 8.
Yeah.
They went away when she was 11
Right.
for 3 years. At that time, the neurologist said, "You're good. You're golden. If
Right.
they go away before puberty, you have a very low chance of it ever coming back."
Perfect. Yes.
Well, then she hit puberty and they came back. And now he says, well, that's it. She's in it for life. True?
Yes, very true. Because well, I'm going to qualify, right? Because remember, this is not 100%, right? There's a 15% here on this side, right? So the ones who actually switch over to this one usually end up on this one of the two, the juvenile. And then once they get here, the diagnosis changes to juvenile myoclonic epilepsy. And if you have this, then it becomes lifelong. So maybe your son, your daughter,
Hormonal and everything.
probably has juvenile myoclonic epilepsy. The nice thing about this is I have only seen maybe 1 or 2 patients with JME I cannot control. So the nice thing about JME is their seizures are easy to control if they only tolerate the medication. So the ones I have seen who are not controlled have problems with medicine. They have too many.
Medications for JM.
Depakote, Lamictal, the big ones. Yeah. Capra, yeah, could be. Yeah. But usually they do well with Capra, Depakote, Lamictal. For female, stay away from Depakote. Lamic, I don't, because it affects your ovaries. You could have polycystic ovarian disease with Depakote. So, and then the incidence of neural tube defect is high on patients. Incidence of malformation is higher in epileptics, period, right? And then you add epileptic plus seizure medication, it even goes up. And one particular medication you need to avoid in epileptics is Depakote, because you have neural tube defect. You have myelomeningocele, you have a hole in your spine here, a hole in your spine there, because the pores, they don't close. So what we normally do is, okay, you're 15, 16, I know you're not thinking about pregnancy yet, I hope not, but I need to tell you this. I need to take you off of Depakote and I need to put you on folic acid. And folic acid is supposed to make it less likely to happen. It doesn't completely protect you from having birth defects, but it's less likely. And you have to take a lot. Normal pregnant women take 1 milligram, you have to be at least 4 plus milligrams of folic acid. So we tell our patients, if you're planning, and the key word is planning, to be pregnant, you need to let us know. So we need to put you on a folic acid, whether you're on Depakote or not. Hormones could do tricks with your seizure threshold, much like what we call catamenial epilepsy. Catamenial epilepsy is epilepsy related to your periods, right? So they have more seizures at a certain part during their menstruation because of the imbalance in your hormone. And it occurs just in that particular day. So every month, you know, on 2 days before they have a period or in the middle, catamenial, C-A-T-E-T-A-M-E-N-I-A-L. Catamenial epilepsy. You could see hormonal seizures in both boys and girls, but more in women. Well, catamenial, because it's usually related to hormonal and some fluid imbalance, usually they don't have seizures only on the menstruation, right? But they cluster and they have other seizure types. So most of the time they have multiple seizure types, and so they have different medications already. If you truly have catamenial, we could put you on a fluid pill like acetozolamide, perimenstrual. So, okay, I want you to sit down every month, get a calendar, and tell me when your periods are going to occur and when you're going to have seizures, and then we could decide when we could give you acetozolamide. So it's not going to help your other seizure types, right? But if you're clustering at that time, your seizure number may go down just by adding medication that you could take during that month. So remember, EEG is not a good test. It doesn't tell you, it's not used to diagnose epilepsy, right? Oh, what's the difference between seizure and epilepsy? Correct. That's it. If you have more than one, seizure is the manifestation of epilepsy, right? Everyone with epilepsy has seizures. I told you already, 10% of the population will have a single seizure. He's not an epileptic. Kids with febrile seizure, not an epileptic, because those are provoked, those are due to fever. So if you have more than one unprovoked seizure, you have epilepsy, period. It doesn't mean you're going to be slow, doesn't mean you're not going to be able to go to school, and so on and so forth. Just simply, if you have more than one. So, you have to listen to your patients, get a good detailed history. If it happens in school, you call the teacher or whoever saw the event and say, describe it to me from start to finish. Nowadays, most of my patients, one sentence, they pull out their phone and you know what's coming. You know, this is what he does. It's very helpful. It doesn't have the EEG, right? But there are features that you watch for that says, that's a seizure, that's not a seizure. And not everyone jerks has a seizure. Say that again, I'm sorry. Yeah. Well, that's a, in general statement, I want you to take a video full body, but if I know your son does this, I don't care about the foot. Just zoom me on the face, right? There is a seizure called benign Rolandic epilepsy of childhood. What do? You put them in bed, they're half asleep, they get up, get to your room and say, Mom, I can't control it. They're awake, it's simple partial seizure, but it's affecting their face, and then one night, it's on the other side. 95% of those kids will outgrow their seizures. So.
Have you seen genetic cases that actually stop seizing?
Yeah. We have cases now that you put them on video EEG monitoring and you identify their seizures. And a lot of the times we do genetic testing nowadays, right? So you see a genetic abnormality. Say, yeah, but he's not seizing anymore. So what do you do? So again, go back to not everyone that shakes has a seizure. If you're going to have seizure, I don't want to teach you this, but if you're going to have seizure, you jerk on the plane of your flexion extension, right? So you see a person having generalized tonic-clonic, they do this, right? They don't do this. So there are things we watch on EEG, on video that says, no, that's not a seizure. Most patients with seizures, their eyes are open or closed.
Hers are always open.
Yes.
At night, she has them when she's sleeping.
So a kid or anyone who often tries to fake a seizure, they come to you like this. And you cannot open their eyes because they're forcefully closing their eyes. No, kids with seizures, they don't Most often they don't close their eyes. They're jerking. Yeah, so there are things we watch out for. There are kids who are good. They pee on themselves. Oh yeah, I had an adolescent pees on herself. She falls on the floor, but we've recorded it and say, no, you're not having seizures. So that's when EEG becomes very helpful. Because most of the time they shop physicians. They go from one place to the next. So they're on multiple meds. And they're not supposed to. Any more questions? Well, thank you. I'm around, so if you have any more questions, you could stop me.